everyone, and welcome back to the Carlat Psychotherapy Podcast. This is the second episode in our Borderline Personality Disorder series, where we're exploring the range of evidence-based treatments for BPD to help clinicians better understand the interventions available. I'm your host, Abigail Rossell, and today I'm joined by the one and only Dr. Frank Yeomans to discuss transference-focused psychotherapy, an often lesser-known yet highly effective treatment for borderline personality disorder. Dr. Yeomans is one of the developers of TFP and has played a central role in expanding its clinical use through the co-authorship of treatment manuals, clinician training, and supervision. He is a clinical professor of psychiatry at Weill Cornell Medical College, director of training at the Personality Disorders Institute at Weill Cornell, and director of the Personality Studies Institute in Manhattan, amongst many other roles. He's also the president of the International Society of Transference-Focused Psychotherapy. Dr. Yeomans has devoted his career to advancing evidence-based psychodynamic psychotherapies for personality disorders, and so it truly is an honor to have him here with us today to discuss this very important work. So welcome, Dr. Yeomans. Thank you so much for joining us.
Thank you, and I do want to thank people for listening because, along with everything else, I'm a big advocate for people who suffer from BPD, and there just aren't enough clinicians, so anybody who's interested in helping this patient population is doing a great service.
So I'd like to start off by just speaking a little bit about how transference-focused psychotherapists conceptualize personality disorders and how that understanding sets the stage for the model of transference-focused psychotherapy.
That's a good place to start because if our goal is to help people with personality disorders, we have to have a concept of personality. It used to be that personality was defined as categories that were determined by traits, but personality disorders have a core common factor, which is the experience of self in relation to others. So personality is the way we experience ourselves and the way we experience the world around us. And that can be either successful and adaptive or maladaptive and frustrating. And people with personality disorders are unfortunately not able to adjust well because of their difficulty accurately perceiving what's going on in them and around them.
So if I'm not mistaken, it sounds like what you're starting to touch on here is this idea of the object relations model. Could you speak a little bit to how that informs the conceptualization that you're talking about here and transference-focused psychotherapy in general?
Essentially, an object is another person. So we talk about emotional states, not only in terms of what emotion is being experienced, but what is the object of the emotion and how does that all compute in the patient's mind. The idea is that in the course of early development, inevitably, there are moments of satisfaction and there are moments when the needs are not satisfied. When the caretaker is satisfying the baby's needs, we're in heaven. But in those inevitable moments when the desired care is not available, there's no idea, I just have to wait. The idea is I'm being made to suffer. In the course of healthy psychological development, those extreme opposites merge into more complex experiences of self and others. But before we get to that integrated state, we have our minds organized in the split organization, where one segment is heaven and the other segment is hell. It's too scary to hate your caretaker, so you project everything that's aggressive on the outside world. Now, when we reach the integrated state, we realize we have anger and aggression, as well as love and affection, and so do others. And this is essentially the path we want to help our patients achieve, to go from splitting extreme experiences to a much fuller and richer experience of self and others.
Do you have a clinical example of what that split organization can look like in practice and how it can show up in the patient's life and in the treatment room?
Okay, here's the clinic example. A patient of mine started therapy with quite a history of acting in an aggressive way towards her husband. So after about 2 years of therapy, She said in a session, you've helped me and my husband and I can get along now and have a good time, but you've also taken something away from me. I used to think I could find the perfect other, and now I realize that's not possible, and that's sad. So she was describing in her own words what we see as the evolution that we try to help people with. The interesting thing was that in the very next session, she said, it was hard for me to come here today. I feel so guilty now about things I did to my husband that at the time I thought I was justified in doing. I realized now I was acting in an aggressive way, and it's painful to think about that. So that's the change we try to effect in our patients. But that's also why it's hard, because they have to come to these sometimes painful awarenesses. So if we have the idea that in the mind of every individual, we have internal representations of who we are and who others are. The question is, how well do those internal representations approximate external reality, or how different are they? And in patients with borderline or other severe personality disorders, the internal representations don't fit well with the external reality.
For a clinician that doesn't have formal psychoanalytic or TFP training, or, an outside observer that's sitting in and watching a session, what does that session look like, for those 45 minutes?
That's a great question. And there's a misconception in the minds of many therapists. The therapy consists of two people sitting in a room, patient talking, and the therapist suggesting things to understand as they proceed. But first of all, we need to do a very thorough assessment. And I want to emphasize this because I think modern psychiatry has become a little bit simplistic in their way of assessing patients. Too often, the chief complaint is accepted as the accurate diagnosis. Simple example, patient comes in, you say, why have you come here for therapy? I'm depressed. You write down, diagnosis, depression. Well, what about if the diagnosis is really an underlying narcissistic personality disorder, perhaps of a covert type? So you got the person there. Okay, why are you here? I'm depressed. Okay, can you tell me more about your life experience? Can you tell me who you are? Can you describe yourself to me? If we go back to the basic concept of personality disorder as not having a full-bodied and complex sense of self, you find that the descriptions that people give tell you a lot about what we call their identity integration or lack thereof.
And what would a strong versus weak or less complex sense of self look like?
Clinical example, a man who came in because his girlfriend abruptly left him and he's blaming outside people for having talked her out of the relationship. I said, tell me about yourself. Explain who you are. I'm a very loving man. That was his self-definition. Now, when I went in and got more details about what led up to the breakup, we found out that she'd been physically aggressive with her, but he split that off, couldn't think about it because it was too distressing, and came in seeing himself as the excessively loving victim of mean people who talked the girlfriend out of the relationship. So what I'm trying to say here is that in your evaluation, try to go deeper. We want to know, what is the person's sense of identity? Is it superficial, as in the case of the man I just described, or does it have complexity and depth? Somebody else might have said, well, I really love this woman, but I have problems with anger and sometimes I can't contain myself. That's a more complex version. But the version my patient gave was a split, superficial version. Then you want to get to know, what is the person's experience of others in a symmetric way to their experience of self? Is it complex and rich, or is it superficial? So when I asked this man, describe your girlfriend to me, they'd been together for years, and she said, she's really beautiful, she dresses well, she's kind, and she's sweet, which is nice, but it's almost like, who is she in any depth? So we want to know the quality of the person's identity. We want to know if there's evidence of what we call characteristic defense mechanisms. Do they seem to externalize all responsibility for things on others, or can they see their role in things? We want to get a sense of quality of interpersonal relationships. We want to get a sense of their functioning in life. Are they engaged in a meaningful way in the world? Do they have a sense of productive activity that gives some gratification? It's important to know if there are any antisocial features, dishonesty, or what have you. And if aggression is a major part of their personality.
So once you're done with the assessment, what are the next steps in terms of transitioning into the active treatment?
So we do this thorough assessment. Then if we say, hey, it's not a depression, it's a personality disorder, now we have to discuss that diagnostic impression with the patient in a tactful way, which I'll go into in a minute. Then we have to describe the model of treatment we're recommending. And then a third thing is to describe the conditions that the treatment requires. So here's how we would discuss BPD. We'd start saying, I think the best way to understand your problems and to begin to think about how to treat them is to think about what we call a personality disorder. I know that term might be a little uncomfortable, but we all have a personality. What is a personality? How we experience ourselves and others. It's automatic. It's instinctive. We don't really think about it, but sometimes it's maladaptive. I think we can look at 4 domains in life that are problematic. First of all, emotions. You tend to experience emotions in the extreme, probably more often extremely negative, sometimes very positive, but it's like an emotional roller coaster in your life. Then, after the emotional difficulties, there are the relational difficulties. Relations tend to have conflict and difficulty, hard to find peace and harmony in relationships. Then the third area of difficulty, and this is an area that is the most dramatic, and so it gets the most attention, and in the minds of many people, it defines the illness, has to do with the behaviors and actions. Now, in my mind, these behaviors do not define the condition. They're a surface manifestation. So there might be instances of self-harm, a history of cutting or substance abuse or eating disorder. A lot of treatments just say, let's focus on the behaviors, which is important to focus on. But I think the core of the disorder, sort of lack of a cohesive, solid, clear sense of self. So I'd like to consider those 4 areas of difficulty with the understanding that it's the last one that's probably at the root of everything.
So say that the client accepts the diagnosis, accepts the model, would like to move forward. What does that next stage of, contracting and setting the frame look like?
Let's go there. You've discussed your diagnostic impression. So if the person is at least willing to consider what you've said about personality disorder, then you say, there are different treatments for this kind of condition. I'm going to recommend what we call an exploratory psychotherapy. It's based on the idea that there are parts of your mind that you're not aware of. And these parts of your mind have a big impact on how you feel, what you think, and what you do. And your lack of awareness of these parts of your mind is based on the fact that it's uncomfortable to think about these things within oneself. So if you're interested in this kind of therapy, I can describe the conditions that would be necessary, but that's the gist of the model and an understanding of how to proceed. And then you see if that appeals to the patient or not. So if it does appeal to them, this is where TFP differs a great deal from a lot of psychoanalytic therapy and maybe from other therapies in general. We emphasize the contract and the frame more than a lot of therapies do. We think it's essential to have a clear definition of the conditions of treatment in order for the work to proceed. It's not just about behavioral control. It's about a frame to further understanding. So we say, if you're interested in this kind of therapy, these are the conditions that are necessary. And then we describe what the patient role is, what the therapist role is, We say, your role is to come here regularly to speak as freely as you can with some connection to the topics and the problems that brought you here. My role is to help you understand things about yourself. I listen, I think. If I have a question or a comment that I think might advance our understanding, I introduce it. I do not provide direct supportive interventions. I do not give my opinion about problems you're having unless I think there's a real risk issue. Now, the second stage of contract setting has to do with the particular interferences with treatment that might be represented in the patient's form of acting out. For instance, the patient who has suicidal ideation and has made suicide attempts, that can derail, first of all, the person's life, but it can also derail the therapy because there's nothing that makes a therapist more anxious than the suicide risk. So we have to have an understanding. We say, I know when you're feeling suicidal, it's very intense, but in my experience, people still have a little bit of their mind that they can work with. So if you're feeling suicidal and feel you can't contain it, in this therapy, it would be your responsibility to seek emergency services. The patient often says, don't you know when I'm feeling suicidal, I have no ability to act or to function? I say, a lot of people think that, but I think there's still a part of you that you could try to muster up that could remind you of this discussion and guide you in this circumstance. So we have parameters about suicidal stuff, parameters around substance abuse. We might have to recommend as an adjunctive treatment, a 12-step program. We might have to have drug screening. These are behavioral interventions that are relatively unfamiliar to most analytically inclined therapists, but we feel without the containing of acting out, you can't do a deep exploration. So if the contract is in place, if the patient agrees to it, say, okay, now we can do the therapy.
Okay, so now we've sort of set the stage. You did a thorough assessment, you delivered your diagnostic impressions, you set the treatment frame, and now we're going into an active TFP treatment. And I'm curious if you can take us through what that looks like, your experience as a clinician. What are you tracking in the client? When are you choosing to intervene? What are the intervention strategies that you're utilizing? Really, what is that session like for you as a clinician in the room?
So after we have got an adequate agreement to the contract, now we can start therapy. And that's a real shift from one perspective to another, from setting up the frame to carrying out the therapy. So you say, okay, now the therapy begins. So what do I do? So you say, well, that kind of gets back to what I said, speak freely and say what's on your mind, and I'll be listening. So in the next session, what's very likely to happen is the patient comes in and there's an awkward silence. And I would say 9 out of 10 therapists would say, oh, what's on your mind? In TFP, if you say what's on your mind, you are helping the patient avoid a projection onto you. So if there's that uncomfortable silence, rather than diffusing the anxiety by saying what's on your mind, your question as the TFP therapist is, how are they experiencing me that's making it hard for them to report freely what's on their mind? So you'd wait a couple of minutes and you'd say, we agreed you'd say what's on your mind, and that's not happening. I wonder how we can understand that. So then I say, it's just tough for me to know what to say. So, oh, that's interesting, because I guess there are things on your mind, but you're not sure they're okay. And I'm wondering if you might be thinking that if you spoke, you might encounter criticism or judgment from me. So you see how instead of just saying, oh, what's on your mind? You say, is there something about your experience of me here that's making you nervous? And that could also relate to problems in the outside world where you anticipate criticism. I wouldn't say that all at once, but that's the direction I would be going.
What are some of the things that you're really paying attention to and tracking in the patient as you've started this active treatment with them?
What I find most challenging for most therapists is they focus on the verbal content of what the patient says. That's the patient's telling you information. You process it, you try to understand it. And what about the other channels of communication? The nonverbal, the patient's actions, facial expressions, gestures, the atmosphere they create. And what about your countertransference? The feelings they evoke in you. We feel in the TFP world that the more important information is the nonverbal and the countertransference. I can give you an example from a supervision I was doing yesterday. The patient is a woman around 30 who is trying very hard to have a successful life in terms of work and intimate relationship, but she isn't getting that far. And the interesting thing was I read the transcript of the session before I saw the video of the session. So this patient is saying, I had the worst weekend and I had to spend the time with my boyfriend's family and it was awful and everything was terrible. So I thought, oh, this woman is just suffering and in pain. When we started looking at the video, the patient is saying with a kind of a smile and a lightheartedness, oh, I had the worst weekend. Everything was terrible. They were all so mean to me. And so at that point, it was like, what's going on here? That she seems to be enjoying telling the therapist how bad her boyfriend's family is and how miserable they made her. So then you might say, it's curious. You're telling me about an awful experience, but your affect in the session seems to be positive. How can we understand that? And as the session advanced, we learned that the patient was actually having very harsh, critical thoughts about the boyfriend's family that she didn't want to acknowledge because that made her a mean person. And a lot of TFP is helping people to see they have an aggressive part. That's okay. We all do. It's better to be aware of it and then figure out how to manage it.
That sort of brings me to my next question in terms of what those active interventions in session look like. From my understanding, there are 3 core ones of clarification, confrontation, and interpretation. I'm curious what that one would be labeled as, and also if you could take us through those 3, how and when you choose to use one over the other and the function that each of them serve in the treatment.
Yeah, excellent question. We should talk about those 3 basic interventions, which we consider the core of the interpretive process. And they're not always rigidly carried out stepwise, as in the case I just mentioned. So let's go to a previous case I mentioned, the guy whose girlfriend left him. In that case, a lot of clarification was necessary. I say, from what I understand, you had this really great relationship with your girlfriend. And after this number of years, abruptly, people talked, yes, that's what happened. Was there anything more you could tell me about the relationship? Are there things you haven't said, things I might want to know? And when the clarification proceeded, it turned out that there were these instances when he got physically violent with her. So that's clarification, get more information. If somebody has a borderline level personality disorder, there are going to be discrepancies in what they tell you because things don't fit together. So that's when you enter into confrontation, which is not a hostile, challenging confrontation. We should call it, as Ken Levy has recommended, a bid for reflection. We say, I'm trying to figure out how to put this together. You said it was a perfect, loving relationship. Then you said there were these moments of physical violence. How can we put that together? And then the patient begins to get uneasy because you're trying to bring to their attention what they've been splitting off and denying in themselves. So you have to proceed very tactfully. That's the most delicate part of the process, to try to get them to see what they're projecting. So to get to the case I just mentioned about the young woman who was so miserable with her boyfriend's family, given the discrepancy between the verbal content and the affect of ease and pleasure, you might just go right into a confrontation and say, you're describing a very unpleasant situation, but you seem to be pleased telling me how it unfolded. How could we understand that? And she'd say, well, I don't know. It was really awful. And you'd say, yeah, but you seem to be kind of smiling right now. And she said, I just felt I couldn't even speak up. I felt like totally inhibited from speaking. What was your fear? She said, well, I was thinking how stupid something one of them said was, and I couldn't say anything because I didn't want that to pop out. So they said, oh, that's interesting. So they weren't the only ones with a critical kind of hostile thought, but you're so uncomfortable with yours, you shut down. And then even though it's unpleasant to be the victim of their hostility, it's better than seeing a more complex picture where you might contribute to that too.
Interesting. So from my understanding, even though they don't necessarily appear in these really rigid, almost scripted ways, they do build on one another, and that you need to clarify to set the stage for the confrontation. And then the interpretation sort of arises out of confrontation.
You're setting it very well. So what might be the interpretation? The interpretation might be, it seems that it's so intolerable for you to spend any time reflecting on those instantaneous flashes of aggression in you. It's better to see it in the other, but maybe we'd make some progress by pursuing what seems to have some presence in you that traditionally you just keep totally at arm's length. So that would be interpreting what motivates the projection and the inability to reflect on the disavowed part of the self.
I'd like to get back to this topic that you've touched on quite a bit, which I find to be one of the most fascinating parts of TFP, which is the idea of countertransference. Countertransference is one of those topics that I think can be very abstract and hard to grasp for a non-psychodynamic clinician. So could you speak a little bit to both what countertransference is on the most basic level and also how it's really used as, information and data for the therapist in the session and how it guides your therapeutic interventions?
Yes, we've got to talk about that. It's probably what distinguishes our work more than anything else from the other models of treating BPD. The idea that our reactions provide a window into the patient's internal world. Let's talk generally about the concept because it's a little bit complex. If we define countertransference as the therapist's emotional responses to the patient, first of all, there are two sources of my emotional responses. There's my own life. Patient reminds me of my beloved sister, and so I might initially think, what a lovely person. But of course, I process that and don't let that superficial resemblance influence me too much. But still, your own life experiences inform how you respond to a person. Then we have to talk about the more important part, which is what the patient says and does that evokes a response in you that's from them, not from your past personal history. And when we talk about that, we have to talk about two forms of countertransference, one that goes along with what the patient is feeling and one that is the opposite of what the patient is feeling. So to give you a simple example, young man comes in, university student, says, I'm so bummed out, I failed the exam. And your emotional reaction, the poor guy, I know how hard he tried. That's concordant. You're feeling the sadness and disappointment and the sympathy. If he comes in and says the same thing and your gut reaction is, that lazy son of a bitch, I knew he'd failed the exam. That is probably a complementary countertransference. He's not consciously experiencing that, but that is the internal aggressive object that doesn't let him feel okay about himself, but he's activated it in you. So you might think, oh, wow, I'm having a real harsh reaction to this guy. Is that something he's exporting from his own mind because he doesn't like to think consciously about that part of him? And he is got it going in me. And that helps me empathize with him better, understand parts of his internal world he might not be so conscious of. And you can then tactfully try to begin to talk about a certain harshness in him that may make it difficult to meet life's challenges.
For clinicians earlier on in their practice, how would you say one is able to make sense and drive this really clear differentiation between knowing whether it is their own life experiences and emotions that are driving their reaction to the patient, or whether it is truly the patient's internal experience that is being projected onto the therapist.
Well, first of all, you have to know yourself, and having one's own exploratory therapy is very helpful because you want to know what's in you that could be activated. Even with that, that's why we have supervision groups, because we might have countertransference reactions that we're blind to, but our colleagues might say, did you notice in the video the way you said, well, sir, that seemed to have a little edge to it. So what's going on in you? What's your aggression towards him that came out there? And how can we relate that? So we always say to do good work, you need to have either individual supervision or be in a supervision group.
In terms of utilizing that countertransference, how actively do you confront that with the client? So are you explicitly sharing your countertransference reactions, or are you sort of using them?
No, we use them to confront. I'd say, I see how dejected you are. I wonder if another facet of that might be a real harsh attack that's going on in your mind, something telling you you're worthless. Maybe that's a part of your mind we should get to know better if my hunch is correct about that. So we talk about it being in the air, in the room. But we can say, I'm feeling this. It's actually part of you. I think that sets you up for a lot of problems.
I see. Are there any sort of metrics that you use to determine whether and when material is important to intervene on? You have a client that's free associating. They can be sharing whatever is coming to their mind. Some of it may be more important, some of it may be less. So what points of reference would you use to decide when that's important content to lean further into?
Yeah, I don't think it's going to be a very precise answer, but it's the general principle. We follow the affect, where you feel some emotional intensity, either in the patient, as for example, in the lady who seemed at ease and even pleased with how bad everybody else treated her. You'd follow that affect. Or if you're having a strong countertransference reaction, you follow that affect. But you can't always intervene right away. You might think, how is this affect connected to a dyad? We listen, we try to understand, and then when a dyad might be relevant, and the dyad could be between the patient and us, or the dyad could be between the patient and other people in their life. And I should add, we're not only working with what the patient does with us in the room, we're tracking what they're doing in their outside life, because they could be seeming to be in a nice therapy process with us, but maybe they're failing out of school or behaving in a relationship in a way that's going to lead to a disaster. So we're always keeping track of the external world in a way that's not so common to traditional analytic world. I just have to add that so it doesn't look like we're only observing what goes on in the sessions.
So what are some of the signs that a therapist can look out for that would signal that a TFP treatment is progressing successfully and really going in the right direction?
Well, the delightful part of the work is when they begin to have awareness of what they have spent their whole life projecting. When my patient said, it was hard for me to come here today because I feel bad about some of that stuff I did. When you see this broadening awareness, this opening up to parts of themselves that were not part of their conscious experience of self, that's extremely gratifying. But you have to empathize as the therapist saying, I realize how painful it is to feel guilty. I realize how disappointing it is to give up the idea you'll find the knight in shining armor. But I think we have to go through this painful part to get you to a state where you'll find a deeper and fuller satisfaction in what life has to offer. Generally, patients start therapy with what we call a negative or paranoid transference. You don't like me, you're critical of me, you really want to get rid of me. And we explore all of that. What emerges over time, often non-verbally, you sense it as a therapist in the quality of the interaction. There's a thaw. There's a lessening of the tension and the kind of edge in the sessions. And with time, the person seems a little softer with you. some positive emotion enters in. And it's very important to tactfully name that and say, it seems a little different here than a few months ago. You seem a little more comfortable here. Could that be? And the sad irony with our patients is they're uncomfortable with being comfortable because they don't think it's safe. But what we love to see is the unfolding of healthy dependency wishes to be close that were felt to be impossible before because of the conviction that others would be critical and rejecting.
I'm curious if you could speak to sort of broadening out the TFP principles and whether there are any ways that more generalist practitioners can incorporate specific principles into their work, even if they're not practicing through a strict TFP frame.
There's a whole branch of TFP that's been growing over the past years. It started out when I was teaching at Bellevue Hospital, a big city hospital here. The psychiatric residents treat massive numbers of patients. And I was teaching them TFP, and they said, this is great, but in our setting, we don't have the opportunity to do long-term individual therapy. We see them for psychopharmacology. We see them in the emergency room. We see them on the consult liaison service. But we can use what you're teaching us in all of those settings. And what do they use? They use the object relations conceptualization of the mind. They use the understanding that in the patient's mind, there are the self and other that get projected on the treatment interaction, and that if you understand it, you're going to have a better alliance with your patient. Example, patient who's coming to you for medication and who's not complying with taking the medication. A lot of psychiatrists say, how can I help you if you don't take the prescriptions? That's probably not going to advance things. If you look in the patient's mind and say, I have a feeling this patient is experiencing my prescribing to him as an imposition of my power. And you say, how can we understand you're not taking the medications as prescribed? Do you think I'm just trying to force you to do something and that you have to submit to my will? And of course, that would be an unpleasant thing, submitting to something. So maybe we could think about if that's your kind of gut level experience of my prescribing, if that could have something to do with not taking the meds. So understanding that dyad could help free up the communication between the two parties.
I think some people think that therapy can be, especially psychoanalytic therapy, can sort of be this ongoing, almost lifelong process. What is the sign, really, that the client has gotten everything out of TFP that they can and they are ready to graduate, so to say?
Well, it has to do with how satisfying is the patient's experience in life. Are they able to maintain an intimate relationship when they were not before? Are they able to continue at a job or career sort of track or studies when they weren't before? And the role of the therapist begins to shift as the patient has taken in and understood what you've tried to help them know about themselves. Then your role as therapist becomes less active. You don't have to do all the interpretations. They notice it in themselves. And you become a witness to their better psychological and life functioning. And that's usually when you can stop. One of my patients said, I used to so automatically think that anything anybody said to me was negative, a criticism or rejection. Now I see how much I was reading in there. Now I see that what a lot of people do in reaction to me is positive. I didn't see that before. Now I allow for that possibility. And then she paused for a minute and she said, I hope this understanding of things is real. And I said to myself, okay, she's made it because she's learned that whatever your reaction is in a situation, it's good to think about it and reflect on it. And once you achieve that capacity to do your own reflection versus having got sort of standardized, rigid reactions, then the person can usually go off and find a satisfying life on their own.
I think that's a really beautiful note to close off on. I just want to give you the floor if you have any closing thoughts that you'd like to share with the audience on anything that I haven't asked you or touched on.
Well, I really want to emphasize how rewarding the work can be and encourage therapists to engage in helping patients with borderline and other severe personality disorders They unfortunately are still subject to stigma in the field of mental health, but they're suffering a lot. You have to empathize with their suffering and not just see the part that's on the surface. And hopefully you'll have the gratification of helping them achieve a fuller life.
Thank you, Dr. Yeomans, and thank you so much again to our listeners for joining us today. We will be back soon with the third episode of our Borderline Personality Disorder series, which will be on mentalization-based treatment with Dr. Carla Sharp. See you then.